Well, hello and welcome to HealthLine. I'm Jennifer Blomquist. I have the privilege of hosting the program this evening, and I'm so glad you joined us. We have a rare event here. We have 3 guests tonight, which is, I've never done a show with 3 guests on HealthLine, so it's wonderful. All 3 of our guests are women, and they are all gynecologic oncologists. They work together as a team, and they are here ready to answer your questions. They're going to talk about different types of cancers that they treat, what your treatment options are, risk factors, all sorts of things like that, maybe even things you can do to prevent getting one of those cancers. So they have a wealth of information to share with you, and I really hope you will take advantage of the fact that we are live in the studio right here, and that's why we keep the phone number up at the bottom of the screen. So call us at any time. We will be discussing these different kinds of cancers and treatment options and so forth, but please, we would love for you to interrupt us with your question. So the phone number is 969-2720. If you're outside of Fort Wayne, just put the 866 in front of there and it will be a toll-free call. And I would just want to remind you, in case you're not one of our regular viewers, you have 2 options when you call in. The first one is my favorite because you can interact with the doctors. One of them may need to ask you more questions to be able to give you a better answer. So that's a great way to ask your question. We put you on live, but we don't just throw you on the air. You'll talk to a call screener first, and it's really easy, and that's a great option. If you prefer not to do that, I completely understand it. Maybe you're shy or would prefer to just listen to your answer. Just call in. The call screener will get your question, and then I'll ask it for you. So let's go ahead and meet our guests tonight. So make sure I can get everybody's names correct. So I'll start all the way at the bottom of the end of the table is Dr. Christina Duncan, and next to her is Dr. Bogna Brzezinska, and sitting right next to me is Dr. Anya Menzies. So welcome to all of you.
Thank you.
Thank you so much.
We're excited to be here.
Well, it was, when I heard that we were doing a show on this topic, I was expecting breast cancer to be but it's not. It's gynecology, it's all, I would say, in the lower part of the body,
Exactly,
the cancers that you treat. We don't hear a lot about those. I feel like breast cancer kind of dominates the cancer scene, but sadly, there are a lot of other very important issues that can happen in the reproductive area of a woman's body. So why don't you guys tell me what kinds of cancers you would treat? And whoever wants to take it. I know you were all talking about maybe focusing in on a different one, so I don't know if Dr. Duncan,
sure.
do you want to start?
3 of us and any GYN oncologist treats, like you said, the cancers that are of the reproductive tract. So we treat cervical cancer, vulvar cancer, vaginal cancer, ovarian cancer, and endometrial cancer.
And you were going to talk about endometrial, which I think a lot of people have heard of, but they probably couldn't tell you what it is.
Sure.
So.
I think as we age, I think a lot of women get away from getting regular exams because they think, oh, I'm done having children, or I'm done, I already had a hysterectomy. Why do I need to have these important pelvic exams? And so one thing that we think of for endometrial cancer, which is cancer of the uterus, is that is a cancer that is about 3% of the general population can get, and about 70,000 cases per year occur. And so when we have a postmenopausal woman who has any type of bleeding, we are concerned about that. And I think every GYN oncologist would say, please get attention with your OBGYN immediately.
And what are the other symptoms? I mean, you talked about obviously bleeding. So if you're postmenopausal, I know we've had gynecologists on in the past, and they've all said you're not technically in menopause until you've had a full year of nothing.
Yes.
No bleeding, not even light or anything. So if you're so then you are considered postmenopausal at that point.
That's correct.
And if you have any kind of bleeding, that could be endometriosis?
Or endometrial cancer.
Or endometrial cancer, sorry.
So yes, so you're right in saying that menopause is after you've had a full 12 months of no bleeding, and then any bleeding after that is cancer until it's proving that it is not. And again, that's why it's so important to get those well woman exams every year with your gynecologist, because they can be looking and feeling and making sure they don't see anything abnormal and be asking you those appropriate questions to screen for those cancers.
So are there other symptoms besides the bleeding that you should be?
Bleeding is the number one, but sometimes pelvic pain.
Okay.
Other times it can be, if someone's premenopausal, it can be irregular cycles even. And so when somebody has that pain, that cramping, bloating. Those are kind of the main signs of endometrial cancer.
So you can have it before, you could get this type of cancer even before menopause.
Absolutely.
Yes. Okay.
One of the risk factors is anything that has unopposed estrogen. So if somebody's on a lot of estrogen supplement or medication, or if they are obese, we store a lot of estrogen within our adipose tissue, and that can lead to that unopposed estrogen causing that endometrial tissue to get hyperplastic and have abnormal cells within it that can be precancerous and then lead to cancer.
Okay. Go ahead, Dr. Brzezinska. You were going to tackle.
Yes, I was going to tackle ovarian cancer. I just wanted to add one thing.
Yeah.
Is just a reminder that the average age of menopause for most women is around age 52. So I know all of us have frequently had patients that come in and are 58, 60 years old and tell us, well, I've never gone through menopause. I'm still having periods, and that's not normal.
Is that really even beyond 52?
Mm-hmm. So, once you get upwards of that, it's worth at least talking to your
maybe
gynecologist about and further delving into that essentially.
That's a good point. So,
but yeah, one of the other cancers that we treat is ovarian cancer. So this is cancer that starts in the ovaries or the fallopian tubes or sometimes the lining of the abdomen. They're all kind of grouped together. It's probably the one that when people hear about it is the scariest because
I think so too.
Yeah, it used to really be considered almost a death sentence, but probably in the last 5 to 10 years we've come very, very far with new treatment options, new medications, and how we treat it, and so that's no longer really the case. It's estimated that about 1 in 70 women will get ovarian cancer. And unfortunately, it's a cancer that oftentimes isn't diagnosed until later stages because the symptoms of it are very nonspecific. It's, bloating, abdominal discomfort, kind of feeling full early. So very vague symptoms that a lot of people may write off, and even sometimes healthcare providers may write off if you're not persistent about saying, hey, this is not normal for me. Like let's look into this more.
And does it tend to affect older women, or can it run the gamut age-wise?
Usually it's probably women mostly in their 60s to 70s. Okay. The exception would be that there are genetic syndromes that are associated with an increased risk for ovarian cancer. So, everybody's heard about Angelina Jolie, and she has BRCA mutation, which most people know causes breast cancer, but it's also associated with ovarian cancers.
Okay.
And there's other genetic syndromes as well that can increase that risk, and that will usually happen in younger women potentially.
And I know we were going to talk about risk factors as well, so we'll get to that. And then, I'm sorry, Dr. Menzies, you were going to do vaginal and vulvar?
And cervical cancer.
Cervical,
okay. Yeah. So of those, kind of the most common is going to be cervical cancer. Yeah. That affects about 14,000 women in the United States annually in terms of new cases. It's probably the 4th most common cancer affecting women worldwide. And in contrast to ovarian cancer, we actually have some good screening tests for it. The Pap test.
The Pap smear is
exactly.
That would test for it.
Exactly, and that helps us diagnose a lot of early cervical cancers or precancers that we can treat and kind of get better outcomes because it's something that we can find early and treat early.
And then what about? I don't really ever hear about vaginal cancer. Would you have cervical cancer if you had vaginal cancer,
sometimes,
or can you have just one and not the other?
There can be some association. So vaginal, vulvar, and cervical cancers, they're often associated with the HPV virus, which affects that tract. And so you don't necessarily have to have one for the other. And the vulvar and vaginal cancers are much more rare, but all of those things are evaluated by an OBGYN or your family doctor that can do a pelvic exam. And with those, the most common symptoms, for vulvar and vaginal are going to be if a patient has a mass or potential itching or abnormal discharge. Those are things that should absolutely be evaluated with a physical exam.
I'm glad you guys pointed out that women know their own body, and so, like you, I think, Dr. Brzezinska, you had said if something doesn't seem right for your own body, it may not match what you're, because people, I think, go online and try and self-diagnose. I'm guilty of that as well. But everybody's probably a little different. Right. So you know what's normal for you and what's not.
Absolutely.
I did want to talk about treatment options and risk factors and things like that, but we did have somebody in the meantime call in, and whoever would like to address this, feel free. A woman named Grace called, and she said that her flow has become extremely heavy, and is lasting for 7+ days, and wants to know if this is a sign of something serious. Now, we don't know her age, so.
Yeah, so thanks for your question, Grace. I think that it really is age dependent, but really any cycle that's lasting more than 7 days is considered as some sort of abnormal uterine bleeding. So probably really important just to talk to your OBGYN and see exactly, so she can kind of see exactly how long those cycles are, how often they're coming, and just something important to get checked out.
And I do think that, you know, there are a lot of benign things that cause abnormal bleeding or heavy bleeding or changes in periods. But, you know, we see kind of the worst of the worst.
Right.
And when people get to us, it's usually to rule out a cancer. And so that's kind of always at the top of our list. But just because there's a change, you know, we don't want to incite panic either, but just promote awareness and making sure people are getting their exams.
And still, no matter what age you are, is it still recommended yearly? Or does it ever, I guess we could talk about risk factors that would maybe change it a little bit, but in general, everybody should try and go every
absolutely.
year.
Even, you know, for younger patients, you know, maybe getting started with their pap smears and getting those evaluations, talking about birth control, those are things that, you know, they should see with their OBGYN for, and then kind of as time goes on, having their gynecologic visits for pregnancies, and if they have abnormal bleeding, and as time goes on further, you know, whether they've had a hysterectomy or not. Some people think, well, after I've had that, I don't need care, but you know,
you still do.
You still do. If you have any other complaints that come up, you know, vulvar vaginal cancers are often not missed because people aren't seen, they don't get the exams, so it's important to continue to get that care.
Okay. Yeah, I didn't think about that. So I just want to remind you that we only have these 3 lovely ladies with us till 8 o'clock. And so the time goes by quickly, and we'd love to answer any questions that you may have for them. We're going to continue talking about different kinds of gynecologic cancers. But like I said earlier in the show, please feel free to call. We'd love for you to interrupt us at any time and ask your question. Again, the phone number stays up at the bottom of the screen. It's 969-2720. Outside of Fort Wayne, still a free call for you, as long as you put an 866 in front of there. Why don't we go ahead and go in order again, starting with endometrial, and just what you're like. Are there certain people certain women who are more at risk for that? I know you had talked about postmenopausal tends to be. And the other question I wanted to ask you was, I always heard about endometriosis. I wanted to ask you the difference between endometrial cancer and endometriosis.
So this kind of goes back to the question about what other causes of different types of abnormal bleeding.
Yeah.
And so sometimes we will have women who have fibroids or endometriosis or adenomyosis, and a lot of times the endometriosis can present as painful periods, and that is basically, there's a lot of different ideas about exactly where endometriosis comes from, but the thought is that there's some sort of gland from the uterus that gets out somewhere that it shouldn't be, and causes a little bit more cramping and some pain. And so that's the difference. The actual endometrial cancer are glands of that lining of the uterus that become abnormal. And so there can be abnormal glands that are complex, atypical, and that is considered endometrial intraepithelial neoplasia, which is a precancerous condition. And so those conditions, again, have the same risk factors. So those can be your unopposed estrogen, obesity, and early menarche, so if you started periods early or you had menopause late. And so in those patients, that treatment for those precancerous lesions of the uterus is usually a hysterectomy or an IUD placement. And then for endometrial cancer, I think I'm jumping ahead a little bit getting into the treatment, but that is very tailored to the stage of the cancer. And a lot of times there's different modalities we will use to figure out the stage depending on the patient's physical exam, their medical comorbidities, and once we have that information, we can make the best decision about how to move forward to determine that stage. The best way to get a stage of the uterine cancer is a surgery, and in that surgery, it's typically taking out the uterus, taking out the cervix, taking out the fallopian tubes and both ovaries, as well as doing a lymph node sampling.
Okay, and biopsy, everything then at that
and
point.
all of that gets taken out, sent to that pathologist, and then they kind of take that over.
All right. Well, I know you were talking to Dr. Brzezinska about ovarian cancer. We actually had somebody call in about a question regarding ovarian cancer, so I don't know if we could address
Sure.
that first.
Absolutely.
So a woman named Janet wanted to know if ovarian cancer is like breast cancer, in that is there a genetic component to it?
Yes. So there is a subset of ovarian cancers that's related to the same genes that can sometimes be associated with breast cancer risk, and those are those BRCA 1 and 2, or BRCA, I think a lot of people call them. So those also have a much increased risk of ovarian cancer, about 20 to 40%. And so a lot of times when we look at family histories, we see breast cancers and ovarian cancers kind of running together in the same families. So if you have a concern, say, you have a mother and an aunt and grandmother that had breast cancers, but they've never been tested for, genetics, that's a good reason for you to talk to your doctor about getting genetic testing to look at, hey, do I have this risk factor? There's other syndromes as well, called Lynch syndrome is probably the other most common one that we see, and it has associations with endometrial cancers, colon cancers, breast and ovarian as well.
And what was the name of that again? The
Lynch syndrome.
Lynch syndrome.
Yep,
Okay.
Yep. So while, again, majority of ovarian cancers are not genetic or not associated with genetic syndromes, there is a subset that are. Most are still random, though, unfortunately.
And you were saying a lot, and I had heard this too, even a long time ago, that it's, a lot of times, that's why I would hear about so many women dying from ovarian cancer,
Yes.
because by the time they would detect it, it was just too far advanced.
Yes.
So I know do you want to mention the symptoms again, and what you would, how would you start looking into it?
So with ovarian cancer, I think the issue is that we don't have a good screening test, unfortunately. There's no good screening that we can do, like we do Pap tests for cervix cancers, but for ovarian, we don't have that. So the main symptoms that people may develop are usually bloating, abdominal discomfort or pain, changes in bowel or bladder habits, potentially early satiety, meaning you only eat a little bit and you already feel really full.
Okay.
Because ovarian cancer tends to kind of, I talk about it. I had a mentor once describe it as a glaze on a donut, but it kind of covers your bowels and covers the surfaces in your belly, and it kind of makes your bowels work slower, and so things don't move through, and that's why you get the bloating, the discomfort, the nausea. So all those kind of really vague symptoms. A lot of us can attribute, say, oh, well, I've been eating poorly for the last few days or whatever, but that's why it's really kind of hard to pinpoint.
Yeah, do you just do it? If you suspect it, that's what it is? Do you do a surgery, or could you do even like an ultrasound?
Yeah, so usually I find that most patients get diagnosed because, they either go into their doctor or go into the ER with these vague symptoms, end up getting some sort of imaging done. So whether they get a CT scan or an ultrasound and we find, a pelvic mass or an ovarian mass or something else that's concerning, and then that usually will kind of, based on symptoms and other lab tests, they end up coming to see us for surgery. And again, management usually is a combination of surgery and chemotherapy for ovarian cancers.
Well, it's good to know. You said like in the last 5 years, it's treatment because I did, I always thought of it as a death sentence, like you said earlier.
Yes. Yeah, we have chemotherapy is still the kind of gold standard frontline treatment, but for patients that have recurrent disease or other advanced diseases, we now have a lot of new drugs that are more targeted. So, people hear about the buzzwords of immunotherapy and targeted therapies, or like a chemo pill. Those are all things that we use in our arsenal as far as treating ovarian cancers as well.
Okay, great. And Dr. Menzies, cervical cancer. So the Pap test usually would detect any abnormalities.
Absolutely, yeah. So the Pap test, it can show precancerous cells as well, or things that can kind of trigger us to want to do some additional testing, additional biopsies, and potentially find something early. Other signs of cervical cancer in advance, or that would trigger workup, would be maybe having abnormal bleeding, having abnormal discharge, patients who have pelvic pain or maybe pain with intercourse. Those are kind of red flags that something is wrong.
I don't want to deflect from your answer, but that kind of ties in with something that a caller wanted to ask. So if you don't mind, I'm going to divert to the question really quickly, and then we'll finish up. I'm sorry. I didn't mean to throw that at you. Shirley was saying that she called in and said she had a hysterectomy, and she was told she couldn't have anything inserted into the vaginal region, like a tampon. Supposedly can't do intercourse. Wanted to know why that is, and if you can explain.
I wonder.
Or do you think that
I
sounds
wonder,
right?
is that in the short term, maybe shortly after surgery, that was the instruction? Typically after a hysterectomy, we want to make sure, folks are not resuming an intercourse or placing a tampon.
Okay.
Just because at that time, when we do a hysterectomy, there's an incision that's between the cervix and the vagina. And so that incision has to heal too. So we want to make sure that has time to heal without any kind of disruption. So that is for that reason. And that's only for short term, usually 6 to 8 weeks after a hysterectomy.
Okay, but after that,
She can.
everything would be okay.
Absolutely.
Okay, I'm so sorry to do that, but
That's okay,
that kind of tied in right with her question.
No, I want to make
so.
sure people know. Yeah.
So for what are the treatments then for cervical? You mentioned just obviously a surgery then.
Right.
So do you actually try and remove
Absolutely.
any of the mass? I don't know, does it come up as a mass, or are you just scraping cells? Or
It depends. It depends on kind of the stage where it presents. So if it's just a small lesion, sometimes that can be removed with kind of like a large biopsy. If it's a larger lesion, then sometimes people need to undergo hysterectomy. If it presents when it's very advanced, then hysterectomy is not necessarily the best route. Then radiation and chemotherapy is the way to go. And so it all depends on kind of what the stage is when it's identified.
And do you find it affects one age over, a certain age range over others, or?
Probably the most common age is going to be 30s, 40s, 50s is where we see
younger.
it. Yeah.
Okay, all right. And the ovarian, you were saying more like 60s, 70s.
60s, 70s.
And endometrial, obviously, if it's postmenopausal women, probably.
Yeah,
more
usually
of
in the 6th decade, I would say, or 7th decade, and then other times it can be in younger women as well.
All right. I did have, gosh, we must have a lot of shy viewers tonight. Nobody's calling in. They're the nicest people. They would love to talk to you. So we had somebody call in. Sue says that she has three brothers. Wow, they had breast cancer. And so she says she gets a checkup every year. Should she be worried about getting breast cancer? Because we've talked about that on the show a little bit before. We've had, physicians come on and say that men can get breast cancer.
And I guess I'll say this with the caveat that I am not a breast surgeon, I'm not a breast medical oncologist, but again, because breast cancers, again, sometimes can be related to what we treat as well. Breast cancer in males and men is actually almost always associated with genetic syndromes. That's kind of the biggest risk factor there. So I would say for Sue, if her brothers never had genetic testing, I would recommend that they do. Usually we always want to get genetic testing first in the person that's affected by the cancer. If they're unable to or unwilling to, then I would recommend for Sue to discuss with her doctor about getting referred for genetic testing, because in families that do have the BRCA mutations or other genetic predispositions to cancers, that may change and affect what kind of screening is actually recommended. So for BRCA, that usually involves screening several times a year and not just once a year like the annual mammogram.
Okay. Yeah, I'm assuming with cancer, your screening and and even just your visits would be altered based on what you have. I wanted to quickly just to go to one more question, and then we only have a couple minutes left, so we'll see if we can get this in really quickly. Ken is saying that his wife had a hysterectomy and ovarian cancer, and wants to know what signs should other people be aware of in terms of maybe trying to prevent that from happening, or I don't know if there are a lot of things you can do to prevent these cancers.
Yeah, with ovarian cancer, there probably isn't honestly much that you can preventative wise. I would say, and we talked a little bit about the signs and symptoms, again, bloating, increase in weight, feeling like you can't eat because you're full, nausea, vomiting, those types of things. I will say that the one preventative thing you can do for ovarian cancer actually is take hormonal birth control. So we actually know now that most ovarian cancers start in the fallopian tubes, and we think that some of the pathogenesis or the process that leads to cancer development begins with, every time you ovulate, so every time your ovary releases an egg, there's a little bit of inflammation that happens there near the end of the tube. And that inflammation over years and years and years of having periods, having menstrual cycles, may sometimes cause abnormal changes that can then lead to a cancer. And so taking a birth control pill, so if you're not planning on getting pregnant or not trying to get pregnant, a birth control pill will shut down the normal ovulation of your ovary, and so you don't have that same exposure, and so that actually is very protective. And it's estimated that there's about a 50% risk reduction in your risk of ovarian cancer with about 10 years of hormonal birth control use. And that effect lasts even beyond when you're not using it anymore. So.
Okay. Yeah, I'd never heard that before, so interesting. Yeah. I feel terrible. We only have 15 seconds left. I should have demanded an hour-long show. This time we'll have to have you back, but it's wonderful to talk
Thank
to all
you for
of you.
having us.
Thank you so
Thank
much.
you so much.
We're
I
happy
guess
to be here.
Big thing is, if something seems out of whack for you, you should get it addressed, definitely. So we have Dr. Duncan, we have Dr. Brzezinska, we have Dr. Menzies. Thank you so much, ladies. I appreciate it.
Thank you.
Thank you.
And thank you to all of you who called in tonight. Even though you were shy, it's okay. But I'm glad that you called in and got some of your questions answered. Take care. We'll be back next week with another HealthLine. I hope you have a great rest of your week. Bye-bye.
PBS Fort Wayne was made possible in part by
Momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.